по менеджменту болю, а зараз надаю слово нашому шановному лектору. Ольга, we are ready.
Thank you so much for your introduction. So let me share my screen. Could you let me share the screen?
Just a minute. Just a minute. Not share. Антон Васильович, якщо ви мене чуєте, то щось допоможіть в появі екрану.
Try now, please.
Sure.
О, окей, Ольга. It's okay. We can see your screen.
Okay, from the beginning. Okay, good. Can you see the screen, right?
Yeah.
And so thank you so much for having me. And today I will continue my lecture on pain management. This is part 2 of pain management. Of course, this lecture would be focusing on the cancer pain management. But the general principle of pain management can be applied on any chronic pain, regardless of etiology of this pain. It can be applied for chronic neuropathic pain, pain related to neurological condition. Of course, cancer pain, patients have shorter prognosis usually. It's a little bit different. And as I mentioned in the past, we have special HWO pain management ladder created in the beginning of 80s. Objective for today, we will review again HWO ladder, cancer pain management. We will talk about adjuvant, we'll talk about opiates and non-opiates. So we'll review some pharmacology and clinical pharmacology that can be important in specific patient population. So we will talk about long-acting and short-acting opiates, opiates conversion. I review some interventional pain management and pain crisis management. And we will have a couple clinical cases and a couple questions. It's always good to have interactive discussion. So again, HWO pain management ladder, we will climb up. 4 steps. First step, mild pain when we use non-opiates. Non-opiates, it's NSAIDs plus adjuvant treatment. Mild to moderate pain, we use weak opiates plus non-opiates and adjuvant therapy. Short and step 3, it would be strong. When patient experience severe pain, we will use strong opiates plus NSAIDs plus adjuvant therapy. And step 4, severe or very severe pain, we will use strong pain medicine, strong opiates, and combination of non-opiates, adjuvant, and interventional pain management. Of course, on any of the steps, you can use integrative technique. You can use massage. You can use hypnosis, acupuncture, physical therapy. It can be helpful as a combination to the core medicine. So I will talk about adjuvant now. Adjuvants, we call this core analgesics. So there is a several group of adjuvant treatment. The oldest group is probably tricyclic antidepressants such as amitriptyline and nortriptyline. It's relatively good medications. In a small dose can be used for neuropathic pain. So there is toxicity. It's a lot of cholinergic effect. People can experience drowsiness, dry mouth, and it's relatively contraindicated for patient who has cataracts, not cataracts, glaucoma. So elderly can have urinary retention. We have to be careful. Usually dose for pain management as an adjuvant at 12.5, 25 milligram. So the second, we use serotonin norepinephrine reuptake inhibitors, SNRIs, such as duloxetine or venlafaxine. Another name is Effexor. We use as a combination with weak opiates or alone. Duloxetine actually approved for peripheral neuropathy related to oxaliplatin, taxane, or peripheral neuropathy regardless of etiology, or peripheral neuropathy regarding to diabetes. So anticonvulsant like gabapentin or pregabalin, I'm sure that gabapentin or Neurontin, it's GABA mimetic, it's available everywhere across the globe, including Europe, including United States. So we like gabapentin. It has a relatively safe toxicity profile. The maximum daily dose would be up to 4,000. Some people need 300 milligram a day. Some people need 3,000 milligram a day. So it's have some anti-anxiety property and good effect on the pain, peripheral neuropathy related pain or neuropathic pain. So a topical anesthetic, you're probably well aware, topical anesthetics such as lidocaine patch available over the counter in a pharmacy, over the counter 4% of lidocaine patch, and prescription 5% of lidocaine patch. Relatively expensive, can be helpful, approved here for post-herpetic neuralgia pain, but somehow working for many different pain in a very specific patient population. I know any elderly, they love patches, and any Asian patients, they love patches. I don't know how deep lidocaine will penetrate from the patch to the joints or to the metastatic site, but some patient client telling me that it's really working good for them. So maybe partial placebo effect, maybe real, but absolutely safe. So as a topical therapy, capsaicin, it's basically a red pepper compound, can be used in different patches as well, cream. So good for neuropathic pain, safe, but can cause skin irritation. So next non-opiate we use, it's topical NSAIDs. Probably the most famous formulation is Voltaren gel or diclofenac. Again, available across the globe. Can be helpful for joint-related pain or musculoskeletal pain, safe, absorbed well, depend on the formulation. So antihistamine, helpful, especially we use a very kind of not fancy and not expensive antihistamine called hydroxyzine. So hydroxyzine, old, cheap, but can be used for patients with anxiety, can be used for patients who, in addition to pain, has nausea, especially nausea from opiates. And hydroxyzine was studied for in patients with post-traumatic stress disorder. I use this a lot. It have a no addictive potential. Good medication, safe medication. You can titrate as well. So corticosteroids, one of our favorite medication. In the United States, we use dexamethasone, and I will have separate slide on corticosteroids. So almost no contraindication to use corticosteroids. Of course, if you use prolonged period of time, you need to watch for opportunistic infection. If you use for prolonged period of time, you need to check blood sugar. So, and adrenal insufficiency if you stop corticosteroids suddenly. So biphosphonate can be very helpful in patient who has bone metastasis. Biphosphonate is indicated. Usually we use every 4 to 12 weeks. 12 weeks have enough data to support using biphosphonate. So cannabinoid, medical cannabis, very helpful in conjunction with different adjuvant and opiates as well. And I have another slides, and we use a lot of patient self-medicate as well. So if we go back to our step 1, non-opiate, probably the most widely used medication, it's acetaminophen. In Europe, it's paracetamol. Here in the United States, Tylenol. So mechanism of action of paracetamol not completely clear. It's worked centrally, not on periphery. It's inhibit COX-2. So very important to know that there is no effect on platelets function, platelets aggregation. It's safe to take prior to surgery, after surgery. So another important information, and frequently it's misconception, I don't take my Tylenol or paracetamol because it's dangerous for my liver. No, many study was done. You can use paracetamol in patients with chronic liver disease, including cirrhosis, patient with liver metastasis. Absolutely safe to use patient with chronic liver disease. Paracetamol you can use up to 2 grams a day. It's completely safe. Usually on daily basis, I use paracetamol up to 3 grams a day. So of course we inform patient if they have any ongoing alcohol use or abuse, we try to avoid paracetamol. So paracetamol is also existed in a liquid form for patient who has difficulty swallow, and also in suppository form. So please use, and please for chronic chronic pain, use paracetamol around the clock because it will work better. So another group of NSAIDs, another group of non-opiates called NSAIDs. You guys are all familiar with this medication. More than 20 drugs exist. Some of them more toxic, less toxic, more popular, more expensive, less expensive. But commonly we use ibuprofen, naproxen, indomethacin. It's good for throbbing, aching pain, and musculoskeletal pain. So we usually hold this medication for patients who has low platelets or planning to have procedure. We try to avoid this medication for long-term use if patients have renal insufficiency. So we recommend patients to take this medication with food to reduce gastric irritation. Some of them available in suppository and liquid form can be helpful in hospice setting or when patient not able to swallow. So another part of non-opiates is COX-2 inhibitors, well-known Celebrex, Celecoxib, Nimulid, Nimesulid. We don't use Nimesulid or Celebrex too much in the United States because potential cardiovascular side effects. However, cancer patient who has significant cancer-related pain, the life expectancy is usually significantly shorter compared to patients with rheumatological disorder when they use Vioxx and Celebrex and study and prolonged period of time regarding cardiovascular side effect. I don't feel that this side effect should prevent us to using Celebrex, but you have to watch for fluid retention and try to avoid patients who have significant pre-existing cardiovascular disorder or have prolonged life expectancy. So this medication has no effect on platelets aggregation or bleeding time. So significantly less chance of gastric irritation. So we need to monitor hepatic function when we use this medication, and suppository form also exists. So our next step when we have moderate pain and we use non-opiates plus weak opiates with or without adjuvant treatment that I just mentioned. So weak opiates, it's many different medication in different country approved. So the most common, it's codeine, hydrocodone, tramadol. It's frequently combined with paracetamol, acetaminophen. So, and maximum dose of this medication, especially when they combine, usually related to acetaminophen. So in the United States, we have a good formulation called Ultraset. It consists from Ultram or Tramadol 37.5 milligram and acetaminophen 325 milligram. Absolutely, it can be used up to 300 milligram of tramadol and less than 3,000 milligram of acetaminophen. So all NSAID provide addictive analgesia when giving with opiates, and it can increase and prolong duration of the opiates. So some tips, interesting enough that caffeine, drinking cup of strong coffee along with opiates will improve pain control, decrease somnolence, and increase physical function. This is effect well studied. As you know, there is several formulation, usually for migraine, when one pill consists of caffeine, weak opiates, and some NSAIDs. But sometimes I recommend patients to drink coffee when they take morning pill of weak opiates, well tolerated. So cannabinoid or medical cannabis study well already in terms of opiates and combination with opiates use and pain control. Decrease total use of opiates up to 78% reduction of mean opiate dosage for patients who certify for medical cannabis use. As soon as United States medical cannabis use was approved by the government, of course, organizations start doing statistics, and statistics is pretty impressive. How much money we can save to use medical cannabis and how safe it is compared to ongoing opiate use. If someone is interested, I can send reference. And step number 3, strong opiate. We should use with or without adjuvant, but still I recommend to use with NSAIDs or paracetamol. So strong opiates, morphine, probably the oldest one. Morphine is available for last 3,500 years. Methadone, interesting medication, very cheap, but have prolonged half-life. So it needs to be titrated. Fentanyl or Duragesic, available across the globe now. Oxycodone, we use a lot. I know it's not always available for in other countries. Buprenorphine, good medication, available in form of Butrans patch. I have separate slide on Butrans patch. Hydromorphone, strong medication. Interesting enough that hydromorphone is lipid soluble, and if anything lipid soluble, it have a high and fast penetration to CNS. Overall, that sense of euphoria and sense of well-being happen very fast with hydromorphone. A lot of cancer patient and non-cancer patient, for example, patient with sickle cell disorder, pretty fast realize that hydromorphone working better for them and requesting hydromorphone, we don't mind. So as you know, side effect of opiates, any opiates, right? It's euphoria, it's sense of well-being, it's constipation, it can be urinary retention, itchiness. So another medication, oxymorphone, is not available in the United States, but it's available in Europe. So we propose that long-acting opiates should be used for chronic pain. A lot of strong opiates available in short-acting formulation as well as a long-acting formulation. Morphine available as a long-acting and short-acting. Fentanyl exists in many forms. I have a slide. Oxycodone available in short-acting, long-acting formulation. Buprenorphine available IV. It's available in patch form, 7 days long patch. Hydromorphone available as a short-acting, IV, and long-acting 1 pill a day. So dosing schedule and titration, this is very important statement that you have to titrate to the pain relief, right? And doses are very individualized. The right dose, whatever I take to relieve pain, I never know how much specific patient needs for pain control until we start and until I see effect. Of course, we would like to have a balance between pain control and toxicity. So also important to consider available routes of administration opiates such as oral, rectal, transdermal, transmucosal, transbuccal, subcutaneous, intravenous, epidural, and intrathecal. A lot of different routes available for strong opiates. And you will use most appropriate, right? If patient suffering from severe mouth pain, mucositis, because they're getting radiation for head and neck cancer, you try to avoid oral route. You will use transdermal or you will use IV route for this patient or patient with esophageal cancer who cannot swallow. So patient who has reliable oral intake, morphine is generally considered a standard drug for a drug of choice for cancer pain. And a lot of time we convert different pain medication and we use morphine equivalent. So I know morphine is not easy available in Ukraine, and approximately tramadol 300 milligram a day, it would be 650 milligram pill a day. It's equal to morphine 60 milligram a day. Side effect different. So study were done 20 years ago. Again, if someone is interested in specific reference, I can send the reference. We try to avoid tramadol in elderly because cholinergic property. So fentanyl, I know that fentanyl is available, and fentanyl exists in many forms. Transdermal, called diuretic patch, maximum 300 microgram over 72 hours. Oral mucosal, called Actic. So Actic is actually fentanyl lollipop. You cannot use this medication for patient who is opiate naive, never had opiates before because it's too strong. Actic can be used for patient who has breakthrough pain, paroxysmal pain, or pain related to movement. Basically, it's working immediately in the same buccal fentanyl. It's a special film placed inside patient mouth called a Fentora or brachial. It's pretty expensive and we use rarely because we have different formulation, more cost efficient. Nasal fentanyl, pepfent or Instanil as well can be used as basically nasal spray, especially helpful for patients with severe paroxysmal pain or patient who cannot swallow or nurse not readily available. So intravenous fentanyl exists. Of course, we use inpatient setting. So fentanyl is fat soluble. It should be placed correctly. You need to have some fat in order fentanyl to work. There is a warning on transdermal fentanyl that it should be not used for patient who has less than 50 kilo. So frequently I see patient who has cancer-related cachexia, no fat, and fentanyl sitting somewhere in collarbone, or there is no, it will not work unless patient has subcutaneous fat. And fentanyl patch start working about 16, 18 hours after application. Make sure that on this 16, 18 hours, your patient is covered by short-acting medication. They will not expect result immediately. And same true for discontinuation of fentanyl. It can be circulating in the body up to 18 hours. So fentanyl is absolutely safe if patient have morphine allergy. It's not overlap and not overcross. This is drug of choice for morphine allergy. If patient have bronchospasm, hives, urticaria, you can use fentanyl safely. Of course, it's good medication to use for patient who has bowel obstruction, head and neck cancer, not able to swallow, or limited oral intake. So we sometimes use fentanyl when patient not able to understand the difference between short-acting, long-acting. It can be due to cognitive dysfunction, could be due to language barrier. For elderly, we also use fentanyl patch. And again, if patient underwent has no fat, we usually try to avoid use fentanyl on, or instruct patient to put an area with some residual fat. So one of the most common use of fentanyl dose, 25 mics in a patch over 72 hours. It's equal to morphine 45 milligram a day, hydromorphone 10 milligrams a day oral formulation, or morphine IV 15 milligram or hydromorphone 2 milligram. So it's relatively costly, but generic exists, and I know it's available in Ukraine. It's available in other parts of the world. And so another good formulation called Butrans patch or buprenorphine. It's in the United States, it's more expensive than fentanyl. It can be worn. This patch continues for 7 days, available in 5 different strengths, 5, 7.5, 10, 15, and 20 microgram an hour. So if you need to transition your patient, especially patient who is who already have some opiate exposure, to Butrans patch, you can go to Butrans manufacturer website, and they have a very easy to use calculator. You can convert from morphine, hydrocodone, transdermal fentanyl, or codeine to Butrans patch, depend how much patient use over 24 hours. So for patient who is opiate naive or using less than 30 milligram of morphine a day, you can start with 5 mics. If patient use 30 to 80 milligram of morphine, you would use 10 milligram of Butrans patch. If more than 80, you try to use more powerful medication. So Butrans patch is totally safe in patient with liver dysfunction. This is your medication of choice patient who is dying from liver metastasis or who has cirrhosis. Very safe with high bilirubin level. So And I promise you a slide on steroids in palliative care. We love steroids because it decreases any inflammation, any swelling regarding of etiology. As I mentioned, we use dexamethasone more than prednisone. It's great medication if you try to manage neuropathic pain, especially acute neuropathic pain, because steroids, it's not a long-term solution, at least systemic steroids. So it's good for bone pain related to metastasis or bone pain related to leukemic infiltration. For example, patient who has AML, acute myelogenous leukemia, or any acute leukemia, they can have significant bone pain due to leukemic infiltration. Steroids can take this pain away within hours, and it sometimes works better than opiates. So we use steroids for patient who has spinal cord compression or any nerve infiltration, any nerve compression. So for patient who increase intracranial pressure due to hydrocephalus related to occlusion of the tumor, due to meningeal involvement or brain metastasis. We use for different type of obstruction, for bowel obstruction, and again, this is not a long-term solution, this is a short-term solution. We use for lymphogetic canceromatosis, superior vena cava syndrome. If someone presented with superior vena cava syndrome with swelling of the neck, face, we usually start steroids in addition to palliative radiation. So we have to remember that steroids have direct anti-cancer action and property in 3 types of cancer: lymphoma, leukemia, myeloma, and plasma cell disorder, also prostate cancer. It's directly act against cancer cells. So steroids as an additional bonus decrease nausea. We use as a part of anti-nausea regimen when we give chemotherapy. It increases appetite and well-being. Steroids with study in hospice setting, so it can increase weight, but we need to watch for diabetes, adrenal insufficiency. It can be thrombogenic, but hard to split why patients develop clots because of steroids or because they have advanced cancer. So in short-term steroids use, we usually don't think about infection. It will not deplete lymphocytes or neutrophil count, and it's not increase risk of infection if you use for short period of time. So now I would like to go over some cases, and if you can, help me, would be great. So we'll chat about pain management in opiates naive patient, pain management in opiate tolerant patient who already use opiate, and we talk about opiate conversion and pain crisis. Definition: opiate naive patient who is not chronically receiving any opiates therapy on a daily basis, and opiate tolerant patient chronically receives some opiates analgesic on a daily basis. So clinical case. So I have 66 years old gentleman with metastatic prostate cancer who has multiple bone metastases. And he graded his pain about 3 out of 4. It's worse with the movement. He's not taking any pain medication. He told me, it's acceptable, I can live with this pain. But it's progressively getting worse. He's on Lupron for his prostate cancer, and radiation oncologist planning to do radiation therapy to the area of painful metastasis. So there is 5 choices. What would you do for this patient? What medication you advise him to start? Fentanyl patch 25 mics over 72 hours, oxycodone 5 milligram orally every 4 to 6 hours, oxycodone 10 milligram twice a day, oxycontin, sorry, Motrin 5 milligram TID, or Vicodin 5 milligram, consists 5 milligram oxycodone and 325 milligram of acetaminophen. 1 pill every 4 to 6 hours. What would you use? So if we go back to our HWO ladder 4, step 1, we should try to use non-opiate because this is patient completely naive to any pain medicine. And my medication of choice in this situation, I would start with Motrin. And I would start with Motrin around the clock. Motrin around the clock, it's great medication for management of musculoskeletal pain. And if patient progress, if it's not enough, I will escalate and I will add on more. And of course, patient will continue Lupron, patient will continue Zameta, and patient will have radiation. So another question I have to you, what's the most appropriate adjuvant analgesic when you're treating somatic pain? Somatic pain, it's again, it's musculoskeletal pain, joint pain, pain related to any somatic body part. So what would you use? Amitriptyline, clonidine, ibuprofen, lorazepam, or neurontin for?
Let me, Olga. Let me. Neurontin, gabapentin.
So gabapentin, it's a great medication for as an adjuvant for somatic pain with neuropathic component. And gabapentin have good property, can help with somatic and neuropathic pain. For somatic pain, we try to offer NSAIDs, and it can be combined with neurontin. And again, neurontin, it's our medication to go, and many sort of pain. I would agree with you. In addition to ibuprofen, neurontin, it's a great drug to use. So, next question. What's the appropriate adjuvant we will use for chronic neuropathic pain? Clonidine, dexamethasone, ibuprofen, lorazepam, or gabapentin?
And maybe combination.
I agree with you. Yeah,
Gabapentin and dexamethasone or prednisolone.
Yeah. And do you use more dexamethasone or prednisone?
Yeah.
And both medications are easy available.
Prednisolone, dexamethasone, and methylprednisolone without problem.
Okay. So go back to our case, prostate cancer patient. 2 months later, his disease progressed, pain worsened, and it's not controlled with Motrin. He's taking Motrin up to 2,400 milligrams a day. What is your next step according to HWO ladder? What's your next step? Increase Motrin, start fentanyl patch, start Percocet or Vicodin, combination with acetaminophen, start MS-Contin, morphine extended release, 30 milligrams twice a day, start morphine immediate release, 15 milligrams every 6 hours, or start Ultram 50 milligrams every 6 hours.
Maybe combination oxycodone and non-steroid anti-inflammation drug.
I totally agree. I think combination would be great as our second step on HWO, and then you have room and you can escalate his weak opiates if needed. Okay. So 3 months later, same patient, disease progress. We switch him to chemotherapy. We add on chemotherapy to Lupron. He's getting docetaxel, but unfortunately his pain is worse. Now he's taking 2 pills of Percocet. Percocet, it's oxycodone, 5 milligram, and he's taking acetaminophen, 325 milligram. He's taking this 6 times a day. So, and we will climb to next step. What would you do? You will start fentanyl, 70 to 50 microgram over 72 hours. You start buprenorphine patch every 7 days. You will start hydromorphone, 2 milligram pure, Q3 hours as needed, or you will start long-acting OxyContin and continue oxycodone plus paracetamol, short-acting. You will switch him to oral morphine.
I would like to give hydromorphone, but we haven't any hydromorphone at Ukraine, and we can give only oral morphine
Okay, but
or fentanyl patch. We have fentanyl sandoz, generic of fentanyl patch.
so I agree. We need to. This is a time when we can switch him to long acting, right? And long acting, again, it depends what is available. A long acting can be fentanyl patch, can be Butrans, can be OxyContin, which is available in the United States and some other country. And OxyContin is long acting oxycodone every 12 hours. And we still can continue oxycodone plus paracetamol as a breakthrough. Oral morphine extended release, absolutely appropriate option, and again, depend on availability. But because he's now taking 60 milligram of total over 24 hours of oxycodone, this is a time when we climb up to third step of our HWO ladder. It's require something long acting in combination with short acting, right? And of course, we try to think what else we can do to help. Maybe he has painful lesion, we can radiate, right? We can do small dose of neurontin, steroids. We still can continue his paracetamol. We can play with paracetamol and morphine, but long-acting opiates in combination with NSAIDs or paracetamol and short-acting opiate would be choice of the treatment here. So, and how we calculate, as I mentioned, you calculate how much opiates he's taking, right? He's taking 2 pills of oxycodone, 5 milligram, it's 10 milligrams, 6 times a day, 60 milligram of oxycodone he's taking. So, and we divide by 12 hours, because majority of patients require for long acting, if it's available every 12 hours. We divide and we will have OxyContin 30 milligram Q12 hours. Patient will take, for example, 8 p.m. and 8 a.m. and he will take for breakthrough pain, short-acting oxycodone plus paracetamol, about 10 milligram as needed every 3 to 4 hours. We have to remember that oxycodone, and if you're dealing with different medication, the reference available, you can check an up-to-date, you can, and I put reference slide at the end of my presentation. You just go by short half-life time. Oxycodone is usually 3 to 4 hours. Every 6 hours a patient is in pain, he would be looking for the pills early. We call this end of dose failure. So some of the patient will tell you that I need more medication before this 12 hours. It's mean probably this patient fast metabolizer, and every 12 hours it's not enough for him. We have a patient who's switching long acting every 8 hours. So, and if you need to convert one opiate to another opiate, oxycodone to morphine, or duragetic patch to hydrocodone or oxycodone. So you go to opiate equivalent calculator. It's available on a computer, multiple website offering this opiate equianalgesic calculator. You basically put your medication that patient currently taking, you put route, pure or IV, put amount of milligram over 24 hours, and then you put in another box medications that you're trying to convert, and it can be oral, or it can be transdermal, or it can be IV. So if this is different medication, you need to decrease the dose of medication you're planning to start by 25% for the cross tolerance, because we're all different. Some patients have more sensitivity to one versus another opiate medication, and computer will calculate the dose. Same true if patient is coming in the hospital, he's on long-term opiate therapy, and he needs to be NPO, he go to surgery, he will not able to use medication because he's not able to swallow. That would be bad to stop everything, right? You need to convert to IV or dermal combination. This calculator is very, very helpful. So, and conversion to oral slow release formulation, calculate total dose of opiate giving over last 24 hours, convert to oral equianalgesic dose, split the daily dose into twice a day if it's oral. So, and patient will still require short acting. It can be IV or pure, and short acting formulation usually 10 to 15% of total long-acting opiate daily dose. And I put reference here for opiates conversion and from clinical calculators and from global pharmacy, very helpful. But you need to go over several cases, try to convert back and forth to be comfortable with this calculator. I know it can be overwhelming when you listen to someone with, try to pay attention to small details. But if you do as a workshop, or if you do when you see the patient, it's pretty easy. So, as I mentioned, breakthrough pain, when patient is suffering from breakthrough pain that it's not controlled with long acting, so, or PO versus IV calculation, again, you need to go to this medical calculator and put correct route. It can be IV, PO, or transdermal. Again, if you try to convert to different opioids, reduce those two opiates you're trying to convert to by 25%. So if you need to convert PO to IV, you calculate the dose, IV dose over 24 hours, and you have option to give continuous infusion, or you have option to give as needed. But as needed, nursing time involved, because patient will call nurse more frequently. 24 hours infusion, if patient especially have port or IV, relatively easy to do. So this is slide pain management tips. As I mentioned, for chronic pain, we prefer to use around-the-clock dosing, regardless what pain it is. Arthritis, you can use around-the-clock paracetamol. If it's cancer pain, you can use around-the-clock paracetamol, Motrin plus opiates. So paracetamol and NSAIDs should be used unless contraindicated. This is, I think, very important, because we underuse this medication. In patient mind, okay, this is simple, this is over the counter, this is cheap, it will not work. It will work. And we see a lot of times that rheumatologists will use paracetamol or NSAIDs around the clock more commonly than oncology use, or more commonly than we see in the hospital. So also use the simplest dose and schedule. Try to work with one medication that can be used as a long-acting opiates and short-acting opiates. If you start with short-acting morphine, you can increase and use long-acting morphine and continue short-acting as needed for breakthrough pain. So it just simplify your pain regimen, and it's usually cheaper. So oral route is still preferred route for chronic pain management if patient is not an acute pain crisis or able to tolerate oral medication. So, and consider drug half-life and organ function, right? If you have patient with kidney dysfunction, liver dysfunction, you can use Butrans. It's safe to use for patient with liver dysfunction, kidney dysfunction. We usually avoid morphine, and liver dysfunction, we try to avoid morphine. If you have nothing else, you need to just increase interval, because it would be circulating longer, patient may have more side effects. But if you have unique patients with organ dysfunction, online, all information available what to use. And so, important slide for interventional pain management. Interventional pain management is more available now. So interventional pain management requires specific training. It's more expensive. It's more reimbursable. And physicians who are doing pain management, they, as their specialty, they prefer to do intervention rather than therapeutic pain management. So frequently we use a special intrathecal pump. We call this IT pump for patients that can be in chronic pain due to cancer, or for non-cancer pain, especially chronic low back pain who fail multiple intervention. Basically, it's a small electronic device that would be installed to patient body, and it would be connected into epidural space via small wires. It's require pain management specialist and neurosurgeon. The pump would be under the skin, and pump can have an option as you can externally programming this pump, and you can externally, like using chemotherapy port, load this pump once a month with pain medication. It's usually hydromorphone or morphine as a choice of pain medication we use. Convenient, and patients have significantly less opiates requirements and with significantly less side effect, because you need to go micro doses. You need to use micro doses of opiates because it's go directly to CNS. So of course, infection can happen. Of course, you need to coordinate the care, and you need to put this in a relatively early metastatic disease phase, because when patient is far away, the patient around the hospice time, frequently they on anticoagulation, they can have infection. It can interfere with placement of this intrathecal / subcutaneous pump. So when I see patient and I anticipate rough disease course, right, especially patient with gynecological malignancy, cervical cancer, vulvar cancer, penile cancer, it can be very, very painful. And they will die, a lot of them, from the local disease progression. because this patient are young, especially cervical or vaginal cancer. This is young patients. They have good hearts, they have good lung, and they will die with significant local disease pain. And I can try to talk to my interventional pain management team early and try to get them to intrathecal pump. So we have to remember about sympathetic system blocks. It's available, again, requires special training. Usually physicians who are doing interventional pain medicine train in this area after anesthesia. They know very well anatomy and they feel very comfortable. They do this under fluoroscopy or CAT scan. There is several blocks exist. Probably the most famous block is the celiac plexus block, and celiac plexus it's in the middle of this picture. So we use celiac block in patient who has visceral pain, especially pain related to pancreatic cancer. Pancreatic cancer can be pretty painful cancer because it can invade the celiac plexus. It's good for liver capsule pain, and it's good for stomach pain, and again, any area of the pancreas. And sometimes we use celiac plexus block for chronic pancreatitis because it does work, and I can tell it worked maybe 60% of time. There is three categories of doctors can do it. Sometimes interventional gastroenterologists can do celiac plexus block through endoscopic technique. Interventional radiology can do celiac plexus block. It's usually the approach from the back. And interventional pain medicine can do celiac plexus block. It can be temporary block when they put some lidocaine and steroids, and if it does work, they can do permanent block. Basically, they will kill celiac plexus with phenol or alcohol. So there is other blocks exist. So I like pelvic blocks because basically you can numb the pelvic area to use hypogastric plexus block or ganglion impar block. Helpful for patient who has painful pelvic malignancy, genitourinary malignancy, gynecological malignancy can be very, very helpful. And a thoracic sympathetic ganglion block can be helpful for patient who has painful rib lesion, invasion to costal nerve, can be very painful locally, and when we do intracostal or thoracic block, they can be pain-free and stop using high dose of medication and have a good level of pain control. So pain crisis in cancer patient, this is oncological emergency, and maybe a couple times a month, I send my patient from clinic to emergency room in pain crisis for pain management. So number one, you make a diagnosis. Number two, you start IV morphine or IV whatever IV opiate formulation you have. Frequently, we give steroids if indicated, and again, a lot of indication in cancer patient for steroids. You titrate your morphine, and you can do morphine every 15 minutes until patient comfortable. You wait, you assess, but sometimes we need to be on patient bedside and nurse giving IV morphine until patient is comfortable. And of course, you need to make a diagnosis and understand what is going on with your patient. Patient develops spinal cord compression or acute cholecystitis. So some patient needs continue IV infusion of opiates. We use just continue infusion, or sometimes we use patient-controlled analgesia when patient can press a button and receive a bolus of pain medication. It can decrease nursing time, can improve patient comfort, and that's a very good to titrate. Sometimes we use this for a patient who does not speak language. We get interpreter and explain patient, press this button, and you will be comfortable, because sometimes they feel shy and not asking for pain medicine. So we do use ketamine infusion. Ketamine is medication approved for 50 years using analgesia, using pre-op setting. We use ketamine infusion inpatient, and also we use ketamine infusion as outpatient. So, and I mentioned interventional technique. If someone in pain crisis, frequently we ask interventional radiology to help if pain related to a specific area of the body. So that's again HWO, cancer pain management ladder, 4 steps. I hope after this lecture you memorize the steps. So thank you, and I think we right on time. Any questions?
Okay, I have a question. Dear Olga, my question, what about local radiation treatment in patients with severe pain syndrome caused by metastasis into spinal column?
So we use palliative radiation all the time. And if we have any spinal cord metastasis, of course, patient we suspect spinal cord metastasis, this is emergency. We immediately call neurosurgery. We start steroids, we start morphine, and we call radiation oncology. Absolutely. And any back pain in cancer, cervical pain, back pain in cancer patient, to me, this is cancer related until I do my investigation and prove that it's not. We can give patient steroids right away. We can give in clinic, and we call 2 services, radiation oncology and neurosurgery. It's proven that neurosurgery in combination with radiation, the outcome and functional outcome is better than immediate radiation alone. Frequently, again, we have neurosurgery very easy, available. Frequently, we do surgical decompression of metastasis, if technically possible, followed by adjuvant radiation. We use radiation a lot, but sometimes patient already was radiated and achieved max dose of radiation to the spinal cord. So absolutely, it's one of our palliative technique. If you're interested, I can probably give lecture on oncological emergencies that including, spinal cord compression, hypercalcemia, tumor lysis syndrome. Yeah, let me know. But thank you. It's a very good question. Radiation can be very helpful in many settings. So, and some malignancy more sensitive to radiation. For example, lymphoma, leukemia can melt, small cell lung cancer can melt away pretty fast under radiation, but some malignancy pretty radiation resistant. For example, metastasis from kidney cancer, metastasis from melanoma, and sometimes you need to use surgery as a first step. So here it's references, reference about how to manage adult cancer pain from National Cancer Institute and from European Society of Medical Oncologists practice guidelines, and also OPS conversion.
Well,
Okay.
Olga, thank you so much for your lecture.
You're welcome. And next
and see you next lecture about management of symptoms.
next week we'll see each other. Okay. Bye-bye.
Okay. Bye-bye.
Bye-bye. And feel free to email me if you need additional reference. Okay.
Okay.
Bye-bye.